Well, it's really a pleasure to be here. I just love being in the position I've been in for the last few years, being able to be part of clinical research as well as seeing patients. Just a little background, Bateman Horne Center is a nonprofit and is a nonprofit organization with this three-pronged mission to improve clinical care, facilitate more rapid research progress, and to create and disseminate educational resources. And this specifically involves ME/CFS, fibromyalgia, other post-viral syndromes, and these related comorbid conditions, with our main focus on ME/CFS. And, you know, there's so many gaps, but there are a few of the big gaps in clinical care and research for ME/CFS I'd like to highlight, because this is how we designed our grants and what we've been working on in the last few years. The first is we have almost no understanding of early stages of illness. And our research, our clinical diagnosis, our case definitions are really based on people who've been sick for many, many years. So the long COVID pandemic has created a unique opportunity to study early onset post-viral illness. The second is the medical community has little awareness or skill in the diagnosis and treatment of orthostatic intolerance conditions. And we know this is present in ME/CFS, and dysautonomia is proving to be a common feature of long COVID as well. So it's important that clinicians know how to recognize it and what to do about it. There are also few accessible tools, especially objective tests, that clinicians can use to diagnose ME/CFS, design treatment, and provide support for disability, et cetera. We're getting a few more, but it's still, by and large, the general community of clinicians really don't know how to use tools that are reliable. And the long COVID pandemic has created really an overwhelming and urgent need for clinicians to recognize long COVID, and at least until the science catches up with the delivery of medical care. And this is really familiar to us, but I think that everyone with ME/CFS will eventually benefit. So the main reason we started looking at long COVID at BHC was to compare long COVID and early post-viral illness to ME/CFS, a long-standing illness, as we've talked about here. Second is to learn about the presentation of long COVID and try to determine what's causing it to help us understand ME/CFS, and to determine if understanding long COVID can help improve ME/CFS diagnosis and treatment. So we have a relatively small project of seeing long COVID compared to the rest of our clinic, and we hired 2 new providers to carry this out so we wouldn't dilute the care and attention we give to our ME/CFS patients. You may be aware of this, but there are really 2 main groups. This is very rough, of course, of those who have lingering consequences of COVID-19. Those are the people who are in the hospital, very severe lingering organ damage. But then there's people that look more like ME/CFS with mild to moderate or even asymptomatic infection, but don't recover, or they actually get worse over time. And this is, we call all lingering unresolved symptoms of acute COVID-19 long COVID. So we don't really know how many of these people will go on in time to meet all the horrible criteria of ME/CFS. And we really set out to evaluate these people. So we, after our preparations, we recruited people from the Utah COVID-19 Long Hauler Facebook group. They now have 3,500 members just in Utah. And we screened online so that we only saw people who were never hospitalized, who were otherwise uncomplicated medically and from the mental health standpoint. And we tried to see people who were sick at least 6 months. And that happened naturally because of the time we started doing this, which was February 2021, February, March. So we've now seen 60 long COVID patients in clinic, and 40 have been recruited for NIH-funded research participation. You've heard a little bit about that with our collaborators. So I'm just going to go through some of the things in a bullet form that we know now that we didn't know before studying long COVID. And I just want a little caveat to remind you that our cohort is relatively small, very selective. It isn't broad research. There may be many ways that who the people are biased by whether they get on Facebook, whether they know about BHC, et cetera, et cetera. So I'm just going to report what we have seen in our cohort, but remember, it may not apply to all long COVID patients. So one thing we asked in our questionnaires was we asked about the major diagnostic criteria, the Institute of Medicine diagnostic criteria that are core criteria, and that is impairment of function in association with fatigue, post-exertional malaise, sleep disruption, cognitive impairment, and or orthostatic intolerance. And in order to apply these, you really have to ask about frequency and severity. So this is the number of people who by questionnaire met the MECFS criteria before we even saw them in clinic. And I'll tell you, these numbers came up once we actually evaluated them in clinic, particularly orthostatic intolerance, since people don't really know what it is. Then these are some other common MECFS symptoms or conditions, and these met those criteria in this percentage of those patients. And there are many, many other symptoms, and it's tricky to ask about symptoms because who knows exactly what that's coming from. For example, these aren't really separate from some of those MECFS IOM criteria, so weakness, sleepiness, palpitations, which can come from the orthostatic intolerance, and dizzy, shortness of breath, et cetera. But you can see these people have a lot of symptoms. And we were it was interesting to know that only a small percentage of our patients who came still had loss of taste and smell because they were quite a ways out from their acute infection. So what else do we know now that we didn't know when we started? Well, many similar comorbid conditions occur in both MECFS and our BHC long COVID patients. And that includes cognitive impairment, orthostatic intolerance, dysautonomia, mast cell activation. I don't know about small fiber neuropathy because I don't know how much that's been looked at in long COVID patients. And we just heard from the inpatient study that skin biopsies really weren't very revealing. They're more likely to be seen in fibromyalgia, probably. We've seen a lot of primary sleep disorders and gut dysfunction, but of course we have seen MECFS, and they have to be technically sick more than 6 months and meet the established criteria. What else do we know now that we didn't know when we started studying long COVID? Well, we know that the post-exertional malaise reported in our long COVID cohort is very similar to the PEM of MECFS. We know this because we've already published a paper, this one on the left down here, a project by Megan Hartle that looked at a large number, 151 patients, and not just, where'd we go? Not just these questions, but a whole host of questions about the quality and the experience of having PEM are in that paper that's in Fatigue, Biomedicine, Health and Behavior. So we compared almost 80 long COVID patients right here with the very same questionnaire. And these are just the very basics, but you can see that how quickly PEM occurs after exertion, whether it's minutes, hours, or day, and how long it takes to recover, several days, at least a week. You can see many, many similarities between these. And these p-values show that there are not significant differences between these groups. And we're working on a paper to compare long COVID and MECFS PEM. What else do we know now we didn't know when we started? Well, we know that orthostatic intolerance is playing a primary role in the impaired function of long COVID subjects that meet MECFS criteria, the ones we saw. And in case you're not familiar with this test, the 10-minute nasalene test, they lie down for 10 to 15 minutes of quiet rest, then they stand up, lean against the wall, and we do heart rate and blood pressure every 1 to 2 minutes for 10 minutes while they're in that resting posture. And this is just an example of one of our long COVID patients, not that old, 45. He'd been sick 7 months. These are his lying down or supine blood pressure and heart rate. So we'll call his heart rate 65. Then these are the same values as he stood, and you can see his heart rate climbs and climbs. And at 8 minutes, his heart rate was 138. Plus, you can see him developing physical signs and symptoms over here. So his heart rate went up 73 beats per minute just from quiet standing. So this is quite severe POTS. You only need a 30 beats per minute heart rate increase to be diagnosed with POTS. And we have seen some kind of orthostatic intolerance or dysautonomia in many, many of our long COVID patients. We've almost started to doubt they have long COVID if we don't find it. This is another way of evaluating what happens during the lean test. It's a little more technical, but you could just look at the graphs and learn. So there's something called narrow pulse pressure, and that means that it reflects the venous pooling and the lack of return of blood to the heart. So pulse pressure is very simple. It's just the difference between the top and the bottom, the systolic and diastolic number. So blood pressure 120/80 has a pulse pressure of 40. Then to normalize this across everybody's different blood pressures, you measure the pulse pressure over the systolic blood pressure. So this example, it would be 33, this equation. That line right there of 25 is considered so abnormal, it might be a state of shock from sepsis or heart failure or anaphylaxis. And you can see there's just two different ways of looking at this, but healthy controls stay well above that line. Our ME/CFS patients, and this is our whole population. We actually did a paper that shows that the early onset ME/CFS are probably somewhere in between these two. And then here are the long COVID patients, or the post-acute sequelae of COVID. So we think this is a really good way to be able to identify significant circulatory failure in this subset of patients. And also, this shows this kind of small, but the blue bars are ME/CFS patients. This is a bit early on when we were seeing long COVID patients. The orange bars are the long COVID patients. Did I say that right? Blue is ME/CFS, orange is long COVID, and the gray is normal controls. And the first set is before the lean test. This is at the end, 9 minutes of the lean test, and this is right after the lean test. And you can see that fatigue, brain fog, being lightheaded or dizzy, nausea, breathing discomfort, and pain anywhere are really very, very similar in ME/CFS and long COVID patients compared to healthy controls. So what else do we know that we didn't know? Well, we know that cognitive impairment in long COVID subjects is severe, maybe even more severe than ME/CFS. But remember, we don't have a lot of early onset data in ME/CFS. We did 3 handheld tests, but I'm just going to talk about the simple reaction time. This is done on their phone, and it takes about 5 minutes for the whole battery of all 3. And let me just explain this. So this point here is the cognitive, the simple reaction time. This is a low is worse, before and after the lean test, before and after the lean test, before and after the lean test. So you can see our long COVID patients start out low, they do recover better. And ME/CFS, this means that doing the lean test itself alters cognitive, simple reaction time and cognitive measures. So we think that studying long COVID can bring us much closer to understanding the underlying pathophysiology of ME/CFS, identifying biomarkers and diagnostic tests for ME/CFS, and using this information to move toward clinical trials and specifically treatment trials that will include both. So what we need is massive funding. We're getting that for long COVID, and constant reminders to long COVID researchers about what we've learned from studying ME/CFS and common comorbid conditions. So I'll stop, show you my team. The red circles are our research staff. These are our clinicians and the rest of our support staff.
Thank you, Dr. Bateman. We just have 3 minutes until the break, but could you tell us how PEM, post-exertional malaise, was defined in your studies?
So I'd have to get the paper in front of me, but we asked many questions to try to define post-exertional malaise in the first paper, right? asked people what it felt like, how long it took to develop, its consequences. I don't remember the exact, but it's the consequences of doing physical and cognitive activity. So I think we'll find that in the paper, but I'm sure I'm not going to be able to tell you exactly today.
Okay, well, that's fine, thanks. And can you remind me the male-female population in your long COVID patients, and if you're seeing differences between men and women?
We haven't seen enough, I think, to be able to make those generalizations. And I think our ratio, I'm going to just tell you off the top of my head, is probably 2/3, 1/3. It's very similar to what we see in MECFS. 3/4, to 2/3 of our patients are female.
Okay, thanks.
But more men than I thought. We're seeing quite a few male patients.
Yeah. Thank you very much. There's some more specific questions, but we'll come back to those during the discussion.